Hello there, it's Dr. Verlage again with our next presentation. Today's topic is substance use disorders, obviously with a special focus and considerations on pregnant and postpartum women. So let's jump in. Before I talk more and go through these slides, I think it's really important for us to think about and talk about substance use disorders as a disease. So to kind of give an example of maybe where that perspective and mindset may be lacking and where I saw it, say, in a place in my training. I was at a training for using Suboxone, which requires extra training, and there were family medicine doctors, primary care doctors, OBs there who came to learn about prescribing Suboxone for opioid use disorder. And the attending psychiatrist asked, so you have patient, you get a urine drug screen, and they test positive for opioids despite being on the treatment. What do you do with them? They've been in treatment for XYZ amount of time. What's next? And we took a vote, and it was very surprising how many of these providers basically said they failed treatment and it's time to dismiss them from the clinic. I want us to think about another chronic disease, diabetes, and you are treating them, you've got them on meds, you've got them on a plan for diet and exercise, and you get their A1C and it's super high. It hasn't helped, it hasn't improved, right? What do we say? What do we tell this patient? What do we do with this patient? Do we say, you failed treatment, it's time for you to be dismissed from the clinic? Absolutely not. That is not how we think about treating patients. That is not how we think about managing diabetes. And it shouldn't be how we think about addiction, right? Can they use more supervision and check-ins? Can they use a different medication regimen? Can they use more support? Absolutely. And that's what that should trigger, not a failure of therapy. So relapse is a part of the disease. What we try to do is we try to lengthen the time of sobriety as long as possible. So, and even in this example, I mean, these people were here with probably a more open mindset to working with patients who struggle with addiction. And even in this subpopulation, really, really stepping into the space of thinking about addiction as a disease is still a challenge. I think it continues to be a challenge for even people who work in addiction. So us reminding ourselves of the biological underpinnings of this disorder as a disease is really important as we move forward and figure out how can we best help patients. So the growing concern, substance use disorders have been increasing in general, and the percentage of people using is going up, and along with them, the prevalence of women of childbearing age and pregnant women themselves, those rates have also been increasing. So generally speaking, we think of pregnancy as a protective time for patients with addiction where they're usually able to minimize or stop using. So it really gives us a window to make the most of our interventions and supports. This motivation, I would imagine that motivation is wanting to minimize exposure to their baby as part of it. So let's make use of it and figure out how we can best help. If a pregnant person is struggling to stop using a substance during pregnancy, it also can cue us in that there's a higher likelihood that they do have a substance use disorder versus abusing substances. The difference there being a substance use disorder is something that affects their daily functioning and struggle to control using and not using, or I would say not using. Okay. There are some disparities that have been found in substance use. Interestingly, white women have the highest prevalence of drug use compared to Black and Hispanic women. However, but Black women have the highest risk of adverse consequences happening related to their substance use. I would imagine there's a lot of systemic issues, leading to Black women having these poorer outcomes. White women, there might be a genetic component there that they are, at an increased risk genetically. So the screening. We've talked so much about screening through other presentations, but it really can, set the trajectory for what happens to that mother and baby long term. So early identification is crucial for improving these outcomes. Universal screening is absolutely imperative. We're going to talk about that more here in a second. And that screening should happen at the very first prenatal visit. Screening should be universal. Does not matter what kind of clinic it is, what kind of demographic they serve, what kind of economic status it serves, or what kinds of patients it serves in different groups. It needs to be screened for because this disease can affect any person. So we also need to be particularly, and be extra mindful of having the patient feel like this is a partnership. Our helping them is a partnership. How do we accomplish that? We use non-judgmental, person-centered language to build that trust, and that is on us. There's already so much stigma. There's already so much shame a patient feels. So helping them feel comfortable with us and feel like, again, we're in a partnership with them is going to help them actually use the resources that can be so life-changing. So there's a number of different screening tools. There's some that are general, that need a quick screen, and the assist. Then there's some that are more specific to pregnancy, the 4Ps plus, and the substance use profile pregnancy. There's a balance to be had of the thoroughness of the information we get and the cumbersome of how long the screening tool is. Some of these, the ones that I like, have a pre-screen, couple of questions. If it's negative, the person can move on to the next part of their check-in, versus if they screen positive in that initial part of the screen, then they can answer more thorough questions. So lots available. Considerations for biological testing. So getting urine drug screens, getting, testing to see if there's anything in their system. We need to do this non-punitively, and I'm going to give you an example of how not to do it, which is how I did it once when I was an intern. Went in to see a patient to do their intake test, had their testing in front of me. They were positive for meth. What did I do? I asked, well, what substances do you use? None. Well, your drug screen was positive for methamphetamine. That already makes this not a partnership. It makes somebody feel that shame. It makes you a you versus them mentality. What's the right way to do it? Is, again, and we have to put our caps on of like, I want to help this person. I know that they're using, how can I make this a positive and supportive space with them? So going in and saying, for you to be here means you've been through a lot. We did your testing and your urine drug screen, it was positive for methamphetamine. So I want to know, what's going on, how are you using it, what's it doing for you, and where are you at with wanting to stop, right? We have to be on the very proactive end of things to make somebody feel comfortable as we navigate helping them. So supportive, non-judgmental is going to help mother and baby. If we can get that rapport, we can have them use less or none, and then everybody benefits. So let's talk about substances specifically. We'll start with alcohol. We rarely have clear data on a lot of stuff. Alcohol is one that we know can be harmful to baby. The fetal alcohol spectrum disorders have lifelong physical, behavioral, and learning problems. There is no known safe amount of alcohol use during pregnancy. There is a book I read when I was pregnant called Expecting Better that argues that other countries do allow for a small amount of alcohol and doesn't seem to have poor outcomes. However, given that the risks are so high and so clear, it is a much more straightforward thing to say no and to not, put women at risk of having to decide what's a lot and what's not a lot to them. The CDC also recommends complete abstinence from alcohol during pregnancy. All this being said is if a woman isn't ready to let it go and she's pregnant, using less is better than using what they're using now. So yes, none is best, but less is better. And if we can get them to use less, again, by talking to them and working with them in a non-judgmental way, that is what we should do. So, alcohol interventions. We do have naltrexone for alcohol use disorder. The data for its use in pregnancy, iffy. One could make the argument that we know that alcohol isn't good and if this helps women, but that is very case-by-case basis. So things that we, have that we can strongly recommend, brief interventions and counseling, a referral to specialized treatment programs where we can have these more nuanced conversations with them about what we want to do for their use during pregnancy. One thing to be very careful about is withdrawal. This is just in general, not just for pregnant women, but alcohol withdrawal is one of the most dangerous substance-related complications that we have. We hear a lot about opioid withdrawal and stimulant withdrawal, and it's incredibly physically uncomfortable. However, much, much less fatal than alcohol withdrawal can be. So if you are working with a patient, I would cut the line off that if they are using alcohol daily, they really need to see somebody if they do plan to stop drinking. Because it needs to be done under supervision and with medications to make sure that they do not have a seizure, which could then lead to death. So that's an important piece of information for all of us to know as we move forward and work with patients. Stopping drinking at any time is beneficial. So it doesn't have to be early in their pregnancy. At any point, if they want to reduce or stop, their baby will feel those positive effects or can benefit from that reduction and stopping it. So never too late for us to help. Cannabis use. Understandably, cannabis use is going up. It's legal now, has been for the past couple years. So women of childbearing age, 15 to 44 has increased. 17% of reproductive aged women have reported using in the past year. In 2021, 7% of pregnant women used cannabis in the past month. That is not an insignificant number, and I'm going to talk about the risks here in a second. These can go up to 12 to 13%, that's 7%. In the first trimester, why? More nausea, sometimes more anxiety, so some self-medicating going on with it. We have clear data that cannabis is bad for baby on multiple fronts. So because it's legal, because it's natural, I think some women lean into it as a safe option for treating things like nausea and anxiety during pregnancy, and that, as far as our data can show, is not so. THC, the active ingredient in cannabis, that's acts on brain chemistry, crosses the placenta, meaning it gets into baby. The receptor to THC, we have natural substances called cannabinoids that interact with the receptor that THC interacts with. THC binds 1,000 times tighter to those receptors than what we naturally produce. And what we know is that these receptors play a very large role in fetal brain development. So you can do the math. Introducing something that is that potent on those receptors to something that plays an important role in brain development will likely have adverse outcomes, which is what our data shows. On top of potentially long-term effects on behavior and cognition, we also see lower birth weight in those exposed, increased risk of preterm birth, and increased NICU visits. So we need to encourage women to stop, if not, minimize if that's just not realistic, before and during pregnancy. There are groups that advocate for using cannabis during pregnancy and try to post information about how it is safe. That is simply not true. So we don't want to be pushy with patients ever about wherever they are in their substance use journey. We do need to be clear with them about what the risks are, and there are clear risks. So, opioid use. So, approximately 6 to 7% of pregnant women report using prescription opioid pain relievers during pregnancy. That could be for a legitimate pain issue. So this does not necessarily mean misuse. The majority of use, 84%, was prescription-based, obtained from a healthcare provider. Misuse, meaning using it not as prescribed or for pain or for reasons other than pain, was reported about 20% of women who use prescription opioids. So 20% of those 6 to 7% who were using it at all during pregnancy. So what's the issue with it? There's something called neonatal abstinence syndrome, which is after baby's born, very irritable, very, crying a lot, difficulty feeding, very poor first couple of days to weeks in life that needs to be monitored in the hospital. On top of that, poor fetal growth, preterm birth, stillbirth, all of these very scary things. So, we really need to take opioid use disorder seriously for our pregnant population. Fortunately, it is one of the only substance use disorders that we actually have a medication that we have tested in pregnancy and that it's safe. Methadone or buprenorphine are those are the medications we can use. Those are the standard of care for women who have opioid use disorder. It helps to stabilize the opioid level, reduce withdrawal symptoms, reduce risk of relapse, and it improves prenatal care adherence, moms even going to their visits for regular checkups, and overall pregnancy outcomes. All good, all things that's exciting and that we really need to optimize as much as possible for these patients. This one I had to do a little more research on, but the abrupt discontinuation of opioids, cold turkeying the opioid during pregnancy, can be harmful to fetus. The data is not the most robust, but there are small studies that have shown this, and so to play it safe, and especially because we got something we can use, let's help them when they're coming off of opioids with a medication-assisted treatment if they're comfortable with it. Okay, so next up is stimulants. Cocaine and methamphetamine, when used during pregnancy, has a number of different serious consequences. They do cross the placenta, which can affect fetal development. So the outcomes that we have the most data about is placental abruption. That's when the placenta separates from the uterus, can cause bleeding and very scary outcomes. Preterm labor and intrauterine growth restriction. Babies not growing well in babies in mom's uterus. So something else we need to really try and help our patients with if it's going on. Frustratingly, unlike opioids, there are no approved medication-assisted treatments for stimulant use disorders during pregnancy. So what do we rely on? Largely behavioral interventions, such as CBT and other forms of therapy. There is some data that Wellbutrin can help. That is, off-label and an option, but should be discussed discussed with somebody who's familiar with using that treatment. And again, not a whole lot of data to support it. But stimulants, we should strongly encourage them to stop or minimize if they're not ready to stop, and to speak to a professional. Somebody who, if the therapist can be a substance use specialist or the provider is familiar with treating patients with stimulant use disorders, fantastic. A lot of discussions with patients who struggle with addiction is about triggers. The postpartum period is a perfect combination of what I would imagine would be a very vulnerable period due to a number of triggers that can happen. Physical, emotional, social changes can all increase the risk of relapse and increase in use. So what are these? Sleep deprivation, fatigue, possible postpartum depression and anxiety, pain that they're managing from childbirth or cesarean sections, not as much monitoring. The average OB follow-up, they're visiting every 2 weeks during the end of their pregnancy, and then they go to a 6-week follow-up postpartum. So less eyes on them, less opportunities for them to ask for help or for us to ask if they need it. And then obviously the stress related to caring for a newborn. So with that in mind, we need a comprehensive, compassionate approach to working with patients that addresses both the substance use that the patient may have and the unique needs of that pregnant and parenting woman. As we've talked about, non-judgmental, person-centered care. We need this to be collaborative. We need this to be a partnership, which means we need to really keep our judgment and language in check. Integrated care models are ideal, combining medication management providers along with therapists, along with parenting supports is going to be, again, ideal, although sometimes logistically just not possible. And trauma-informed care. There is a very large overlap between substance use disorders and patients who have experienced trauma or struggle with trauma-related disorders. So we need to keep that lens also as we work with this population. Last slide, sustaining recovery post-delivery. We just talked about all of the triggers that can happen in the postpartum period. We should not stop monitoring after delivery or at the point of delivery. We need to follow them afterwards. Addressing social determinants, so helping with needs that they need, like housing, transportation, childcare, and finding them resources for those things. Peer support, absolutely. There's from recovery coaches. I remember when I did my addiction rotation, the attending really emphasized the studies and the importance of talking about and checking in about if they're an NA or AA. As always, we are not being pushy. If they don't want to do that, then we are on their team. However, the benefits that they can gain from that are invaluable, and it is something that we should check in about and discuss with the patient. and help them find those resources. It doesn't have to be NA or AA, but something that is a model that resembles that. We should continue with the medication-assisted therapy for opioid use disorders after pregnancy, obviously. And in a perfect world, we would also help with legal advocacy. Obviously, we have to be mindful of, child protective services and what they will be looking for and the issues that can happen when someone has a known substance use disorder. So keeping that in the back of our minds and helping them with resources to navigate that is also incredibly helpful to them and makes us part of that partnership. So that's it for today. Message me if you have any questions, and I will see you at the next one.